My topic is CTO algorithms, Asia Pacific and hybrid algorithm. Now, why do we do algorithms? Obviously, CTO PCI has evolved over the last few years. So standardized algorithms have been developed for better education, training, and more efficient procedure by reducing the risks and efficiently doing these procedures. And higher success rates could be achieved by using these algorithms. And there are some outcomes from international registries who apply these algorithms. That's what I'm going to discuss with some case examples. So starting with Asia Pacific PCI algorithm, this is developed by a group from Japan and Asia. What they do here, you have a careful assessment of the angiogram or multi-slice CT, and if there is a proximal, so main things we look at is the proximal cap and then distal landing zone by bilateral angiogram, CTO length, and then you base your strategy what will best work for the patient. So in CTO Pacific algorithms, if there is a proximal cap ambiguity, then you use intravascular ultrasound to guide your entry for anterior wire escalation. And if there is a poor quality distal vessel and there are good interventional collateral channels, then you straight go on for retrograde approach. And if you choose antegrade wire-based approach, if there is a good re-entry zone distally, then parallel wiring before considering device-based re-entry could be attempted, and then IVUS guided wiring and parallel wiring also take mention in antegrade wire escalation approach. For instant restenosis, from Asia Pacific algorithm team thought that if it could be considered for cross-boss primary crossing strategy for instant restenosis. So this is the overview. Now this is again an extension from Asia Pacific algorithm, who should do these cases and how they should be done. So what they have suggested, if after coronary angiography, if it is reasonable that the JCTO score is less than 2, then it could be performed by operator who could do these cases. If the JCTO score is high and if the operator thinks that more experienced operator needs to be involved, that could be involved in decision making. Now, there's a lot of emphasis on antegrade wire-based strategy in the Asia Pacific approach. If there are residual microchannels, which wire to use, like intermediate penetration force wire. If there's a tapered proximal cap, intermediate wires are useful. If there's a blunt proximal cap, IVUS-based entry, then you need to use a high penetration force wire. And similarly, they mention about if there's a less than 20 millimeter length, it's reasonable to continue with wire used to cross proximal cap. If the length is more than 20 millimeter, then you can step down, which we call antegrade wire de-escalation, to a lesser penetration force wire to cross the distal cap. Now, the main thing is proximal cap. We all know about it, whether it's ambiguous or not. Then there is a distal landing zone. Then we talk about interventional collateral channel. So what is an interventional collateral channel? It might vary from person to person. You see variety of different septal channel morphology here, 0, 1, and 2 in the panel from going from left to right. And then there are various patterns of collateral channel. They might be straight, less than 90 degree, more than 90 degree, corkscrew patterns. And some studies have shown that the corkscrew pattern and the sharp angle at the distal RCA or distal donor artery are independent predictors for difficulty in crossing the collateral channel. So, and then there are various patterns of epicardial collateral channel. You can see direct connections, CC2 type, large connections, very tortuous. So in my mind, the interventional collateral channels are relatively straighter channels, easily visualized, which can be crossed safely into the distal cap. So this needs to be taken into account based on the procedure. Now, Japanese CTO expert registry, they have recently published the data in more than 2,000 patients, around 3,000 patients, applying the Asia Pacific algorithms. And you can see here that single wire was successful in about 81% of cases in anti-wire alone, and parallel wire and IVUS gated wiring was used in about 15 to 20% of the cases with this algorithm. And looking at the retrograde, obviously you can see that the reverse card was the commonest technique adopted, and after antegrade failure, the retrograde was used in about 50% of the cases. Now, coming back to hybrid algorithm, the similar things you look, dual angiography and proximal cap, distal landing zone, interventional collaterals, and CTO length. And they go down the route of if there is an antegrade option, if there is ambiguous proximal cap is ambiguous, and there are good interventional collateral channel, you go down the route of retrograde, and then you decide what retrograde approach you want to use, wire escalation or dissection re-entry reverse cart. They like to call it dissection re-entry. And if the antegrade length is more than 20 millimeter, then dissection re-entry or cross-bord stingray takes precedence over antegrade wire escalation strategies. So this is like two different algorithms from two different parts of the world. This is the registry based on hybrid algorithm progress registry, which was recently discussed. The success rates were equally good, 87 to 90%, major complication around 3%, 0.9% mortality. And if you see here, the antegrade was successful in about 50%, and ADR was done in about 21% of the cases. So about quarter of the cases need antegrade dissection re-entry to achieve 87% occlusion success rate. Similar results are shown from other registries from UK and other parts of the world using hybrid approach. About 1/3 of the cases to 2/3 of the cases need antegrade dissection based re-entry. Now I will just share with you one case. Obviously, like this is the right coronary artery CTO. If you see here, the proximal cap looks tapered, not too bad. There's a distal diffuse disease after the distal cap. There's a proximal distal cap, distal disease. Good, maybe you can call it a good landing zone. Interventional collateral is also present from left ventricular descending coronary artery into the RCA, and length is around 20 millimeter. So if you go down with a hybrid-based approach, obviously both hybrid and Asia Pacific, you go with the antegrade wire escalation strategy in this case. Failing that, you go to retrograde with hybrid approach, or with the Asia Pacific, you might try parallel wire before going to retrograde approach. So this is all about efficiency and decision making. So we tried antegrade wire escalation, as you can see here. The antegrade wire went subintimal in the distal RCA, as you can see from retrograde injection. And then we quickly, without trying the parallel wires, changed over to interventional collateral. So it all depends how good the collaterals are, and the interventional collateral was used, and the reverse start and retrograde wire escalation was performed, and then it needed snaring the wire after getting into the aorta, and I don't want to dwell too much into this. Then this was the final angiogram. So it's all about efficiency and how you want to progress with your case. So more or less similar with both strategies. Now look at this other case here. This is a right coronary angio. If you see here, right coronary artery CTO. I think there's some problem here. If you look at the proximal cap is ambiguous here, going into a large branch. Distal landing zone before bifurcation is present. So there's a good distal landing zone before bifurcation with no major branch. Length is more than 20 millimeters. And there are collateral channels, but the only good collateral channels were epicardial, coming from the left circumflex, or the ipsilateral collateral channel you see here. Now, you might call these collateral channel interventional collateral channel, or they are not interventional collateral channels. So for me, they were not very good interventional collateral channel. It might be difficult to cross these collateral channels. So with hybrid-based approach, you will go with ADR first, and then retro. With Asia Pacific, you go with antegrade wire escalation. So we tried antegrade wire escalation, which was not successful, and then we went straight to knuckling wire, prepare the antegrade cap. So we went with the hybrid antegrade dissection re-entry. Stingray delivery was done, and this RCA wire was passed into the distal vessel, and this was the final result we achieved. We thought the collaterals were not good, so the case was finished efficiently. So I'll just skip, for time's sake, we skip the next case, which was a parallel wire case. And I just want to share with you, which we looked at recently. We did a pooled analysis on all these major registries, comparing different approach, hybrid-based and Asia-Pacific approach. As you can see here, there are two big registries, Recharge and Expert JCTO registry, involving several thousand patients. And there's and there is a JCTO registry looking at these approaches. If you see here, in Asia-Pacific approach, the success rate was more or less similar in all these approaches. As you can see, above 80%. Rest of the things are more or less similar. But here, if you see the 72% antegrade wire escalation, retrograde 30%, as compared to other registries which are hybrid-based, antegrade wire was successful in only 50%, and other 25% needed antegrade dissection-based re-entry. If you look at the MACE events, they were similar if you see the major ACE events, but there was slight inclination of higher myocardial infarction and cardiac tamponade with the hybrid-based registry. Obviously, this is not, these registries are not testing that as compared to Asia Pacific registry, which has slightly lower myocardial infarction and cardiac tamponade rate. So in conclusion, the high success could be achieved, 86 to 90% in experienced hands with these algorithms. 30 to 40% of the patient will need higher end retrograde or ADR techniques, and higher integrated wire escalation success with Asia Pacific algorithm utilizing of parallel wire and IVUS guided antegrade wiring, and retrograde recandalization with epicardial collaterals were used in 1/3 of the patients, and MACE events were low, comparable in all registries. There is a signal of increased MI and cardiac tamponade seen in hybrid algorithm based registries and need further testing. No difference in mortality, stroke and revascularization.